All right, I'm going to go ahead and get started. So welcome to Ultrasound Grand Rounds, brought to you by MetroHealth. Your regular host, Matt Tabbitt, is off today. He's out camping with his family, so we're going to give him his week of vacation. I'm Sandy Werner, and I am going to be talking about the liver and the spleen, normal and not. Okay, so we're going to talk about liver and spleen, normal and not. And, you know, we do fast exams and we look at the liver, sort of. We're really looking for free fluid around it, above it, below it. We don't really look at the liver. And the same thing with the spleen. But sometimes you see these incidental findings and you're like, what am I looking at? And do I need to do anything more about it? So what we're going to talk about today is basically some of these other interesting findings in the liver and the spleen. So of course, I do not have any conflicts of interest. If any of you would like to pay me high amounts of money, I will be happy to advertise for you. So our objectives basically are to know what the normal liver and the normal kidney should look like, and then recognize and characterize some of the abnormalities and kind of make a differential diagnosis. So we have a patient, 38-year-old female with right upper quadrant, a little bit of epigastric pain. And of course, we're a bunch of sonophiles. So the first thing we do when she comes back from triage is grab the ultrasound and we look at the gallbladder, of course. So we're looking at the gallbladder and we have very nice sagittal view. We even have a great view of the neck, little Hartmann's pouch there, but not exactly anything I'm worried about. And the gallbladder and transverse, the wall's not thick. The diameter is pretty good. The CVD, well, it might be a little bit generous, but okay. So yeah, not much there. And you know, they're sending labs now from triage. We have a doc in triage and her LFTs come back and her belly's slightly elevated and her enzymes are elevated. And you're thinking, okay, let's maybe look at the liver. But then you're like, well, what's really normal with the liver and how do I know what I'm looking for? So let's talk a little bit about normal liver anatomy. So going way back to medical school, for some of us, that's really long ago. You'll remember that the liver is divided into the right and the left lobe. And there's also a bunch of segments, and I'm not going to talk about those because I would have to read from a textbook. So the falciform ligament divides the left lobe from the larger right lobe. And remember that's the ligament that attaches it to the anterior of the anterior abdominal wall. And that round ligament, also known as the ligamentum teres, contains the remnant of the umbilical vein. So in portal hypertension, you can actually see that recanalize. So that's kind of the front of the liver. And then the underside of the liver is where we have the gallbladder. And you can see if you just follow that falciform ligament, you can actually find the portal triad and it'll lead you right to the gallbladder. So find that main lobar fissure, the falciform ligament, and it'll just go right to the gallbladder. And you'll notice that the gallbladder is really well anchored at the neck, but it's not so well anchored at the fundus, which is why sometimes it's in really different positions because that fundus can kind of float around. And there's a couple of impressions in the liver for the colon and also for the kidney. So the vascular supply and drainage of the liver is kind of interesting. We have the hepatic veins, which drain the liver. And so the flow is from those veins and into the IVC. And those are shown in blue. And then remember, we have the portal triads, basically starting where the portal vein is and the common hepatic duct and the hepatic artery. As they go into or come out of the liver, depending on which direction things are flowing. And actually 80% of the blood flow to the liver is from the portal veins rather than the hepatic veins are draining, and the portal arteries only supply about 20%. So they're kind of the oxygenated part of the blood supply, but the nutrients are coming through the portal veins. And then to drain the liver, we have the cystic duct. So we have the intrahepatic ducts, the cystic duct, which meets the gallbladder into the common bile duct. So that's our circulatory system. And then, of course, we have the splenic vein coming across, entering the IVC, and you're going to have the splenic portal confluence, right, where they join with the superior mesenteric vein. And so the normal appearance of the liver, you can see it's really very homogeneous. It's interrupted by the vascular structures. You can't really normally see until they start to get bigger, the intrahepatic ducts. And you can tell the portal veins from the hepatic veins because the portal veins have that nice fatty collar around them. And the hepatic veins are they just look like veins running through the liver. They don't have that fatty collar. So on the sagittal image, in fact, you can actually see there's your main lobar fissure going right to your gallbladder. And in the transverse view, you have some landmarks, the spine, the IVC, and the aorta. And then again, just examples of the hepatic vein and a portal vein with that thick fatty collar around it. And you'll notice that it's really almost isoechoic when you look at how echogenic it is. It's almost isoechoic with that right kidney. So the normal liver, homogeneous, got the portal triads, hepatic veins, it's pretty smooth, and it's about equal in echogenicity to the right kidney. And it's kind of hypoechoic compared to the spleen and the pancreas. And then it's like, well, how big should this liver be? And how do I even measure it? Do I know, where do I figure out how long it should be? Well, you're going to measure it in the mid-clavicular line. And you're just going to go from superior to inferior. And this one measures 11.2 centimeters, which is actually good because that's normal. So it should be less than 16 centimeters. And again, measured at the mid-clavicular line. So hepatomegaly is anything greater than 16 centimeters. And if it extends beyond the lower pole of the kidney and kind of goes around it, and then extension of the left lobe into the left upper quadrant over the spleen. Sometimes you'll see the liver is so big that it actually reaches over and goes on top of the spleen. Of course, for everything, there's an exception. And the exception in this case is if you have something called a Rydell's lobe. Now, a Rydell's lobe affects only the right side of the kidney. This is a normal variant. You'll notice that the left side of the kidney does not go over, it's right, ends at the stomach. It does not go over to where the spleen is, but the right lower lobe hangs way down, and it doesn't curve around the kidney. It just hangs way down. And in fact, it actually can go down all the way to the iliac crest. So just know that some people have a Rydell's lobe, and that's actually a normal finding. So what's abnormal? Well, let's see. We can have abnormalities in the ducts. We can have vascular abnormalities. We can have abnormalities in the parenchyma. We can have lesions like cysts and masses. So we're going to talk a little bit about each of those. So taking a look at this particular liver, something should jump out at you kind of right away. And it's like, it's got a lot of tubes in it. It's got too many tubes. And there's like these weird parallel tubes. So yeah, it's like, wow, there's too many tubes and they're kind of too big. And you also notice as you put some color flow on these that they don't have any color flow in them. And this one measures almost 4 millimeters. And so you're like, wait, it looks like there's a vein above that, which yeah, there probably is. And it's a portal vein. There's not color flow right here. And I think that's just because you're right at 90 degrees to the probe, but you can see the color flow in this vein right there. So that little portal duct, or that little duct, should not be that big. And the other thing you'll notice is that it has kind of a stellate conformation. So all of these tubes are going to come together kind of right in the center. And so that's a good indicator that you have dilated intrahepatic ducts. So the criteria for this is greater than 2 centimeters or greater than 2 millimeters in diameter, or if they're greater than 40% of the diameter of the adjacent portal vein. I personally just like using the 2 millimeters. And then they have that stellate configuration, and of course they lack a Doppler signal. So, what are the etiologies of this? Why do we have dilated intrahepatic ducts? Well, if you're lucky, you've got also a dilated CBD, and you can even see like stones in your CBD. And then you sort of know, wow, it's choledocholithiasis. But a lot of times we cannot see this on ultrasound. So it might be a stricture. It might be a mass. There might be something intrinsic, actually inside of the lumen of the gallbladder or cystic duct. And there's something called Mirizi syndrome, which I'm sure everybody remembers very well. And that's when you get a stone that's stuck in the neck of the gallbladder, the cystic duct, and it's putting so much pressure on the intrahepatic ducts that it's blocking them all up. So that can be a big problem, and also cholangiocarcinoma. And the biggest problem with these, in addition to jaundice, is that people can become infected. So they can actually get cholangitis, and that's a bad thing. So when you have these intrinsic issues with a gallstone stuck, or you develop cholangiocarcinoma, you can easily get cholangitis, a bacterial infection that we all know is really bad. And you can also only have like a partial obstruction, because if you have cholangiocarcinoma, it might be only affecting the right side. Because remember, there's a right-sided and a left-sided portal, like right-sided and a left-sided duct, and they come together into the common hepatic duct. So it could only be half of the liver that's affected. And you can also have an extrinsic mass. So if there's a liver mass that's compressing the ducts, you will also get that dilated duct. And, of course, like many things, we can discover this on ultrasound, but we're not always able to find the cause. If you're really good and they have a stone in the CBD, you might be able to find it. But otherwise, the cause is often better delineated by CT or MRI. So vascular problems, well, like anywhere in the body, you can have thrombus. So we can have portal vein thrombus, and you can also have hepatic vein thrombus. I've seen lots of portal vein thrombi, but I have not ever seen a hepatic vein thrombus, but they can exist. And then sometimes you'll see something that looks like this. And I know you all are looking at this image and you're saying, there's maybe some fluid right here. And you're also noting that there's these really small hyperechoic foci, and they seem to have this dirty shadowing. And of course, you all know that this is air. And really, there's no place for air in the liver. That should not be happening. But then the question is, where is this air? Is it in the biliary tree? Do we have pneumobilia? Is it in the portal veins, or is it in the hepatic veins? So pneumobilia is where we have the connection between the GI tract and the biliary tree. And this is often something that we cause, or our surgical colleagues cause, by some sort of biliary instrumentation, some sort of a surgical anastomosis, or even a spontaneous anastomosis. You can also have an incompetent sphincter or get an infection. But usually not so bad if you have pneumobilia. Portal venous gas, on the other hand, every cause is pretty bad. Mesenteric ischemia, obstruction of the bowel, which causes bowel wall lumen distension. If you get a perforated ulcer, if you get intra-abdominal sepsis. So portal venous gas is not a good thing. And according to our colleagues at radiopedia.org, one way to help you distinguish between portal venous gas is that portal venous gas tends to be more peripheral. And if you're thinking about gas in the bile ducts, if you think C for common bile ducts, it's more central. So for example, this air is quite a bit more peripheral than this air. So this is more likely to be the bad stuff, to be portal venous gas. And this is more likely to be in the duct. And then hepatic venous gas is actually going to take the shape of the hepatic veins, and it'll be draining into the IVC. And the neat thing about this is that the gas can actually move with the heartbeat. So as the heart is beating, you'll see the gas advancing and retracting. And this is typically just caused by us, by cannulating the femoral vein, or if we're giving IV fluids or meds through that femoral line. So we've talked about the ducts, we've talked about vascular, we've talked about air, which is never good. And so I'm going to move on to the parenchyma. So you'll notice that this parenchyma, there's not a specific lesion in it, but it's just inhomogeneous. And, everything looks kind of, gallbladder wall looks thick. It just looks fuzzy and very inhomogeneous. And so this can be caused most commonly by cirrhosis or fatty infiltrate, but it can also be caused by metastatic disease or some other causes, fibrosis, hepatocellular carcinoma, or lymphoma. And there's kind of, so fatty infiltrate, whether it's alcoholic or non-alcoholic, you start with the normal liver on the left, and then it slowly progresses to where you start to see the fatty infiltrate, and the liver typically becomes hyperechoic, and you can have areas where it's more dense. They become nodular in cirrhosis. So as we look at the ultrasound images, this is an example of cirrhosis, and you can see that there's ascites, but notice how nodular it is. There's like nodules and bumps in the surface of the liver. So that would be an example of a cirrhotic liver. And you can see in this liver, there's been fatty infiltrate, and it's quite hyperechoic compared to the kidney. And it's also a little bit hard to see the internal structures. Now, the interesting thing about fatty infiltrate is that you can have areas of sparing. So you notice where the arrow is, that it's less echogenic. It's really hypoechoic compared to the fatty liver. And you can also have areas where you have deposits of fat. And so you have fatty focal sparing and focal areas of fat. So those areas are hyperechoic. And those are usually found around the gallbladder, around the falciform ligament, kind of around that portal triad, where you see these areas that are either they're either spared or they're more dense. So this is just an example, and you can see the liver. It's kind of hard to appreciate the structures, and you can see that there's this hypoechoic area right by the gallbladder. So there's focal fatty sparing, and you can see it on the transverse. And then just notice in the lower screen, we're trying to find the common bile duct, and it's really difficult to make out the structures because the liver has been infiltrated. So as I said, it's hyperechoic, decreased visualization of the normal structures, and then you can have focal areas of sparing or infiltrate. So now we're going to move on to some other interesting findings in the liver. And so, this is a 42-year-old female. We have an MVC, and of course, you're scanning through the liver. You're going to start at the top, and you're looking for, free fluid above the diaphragm. Wait. What was that? Okay, we're going to finish our fast, of course, but then we're going to have to go back and say, what is that? Well, it's anechoic. It's kind of round, and you'll notice that it has like really good posterior enhancement. So you're thinking, oh, well, it's probably just a simple cyst, and it is. And of course, you can have multiple simple cysts, most commonly seen with polycystic kidney disease. So this is a 34-year-old who came in with hematuria, and her liver is affected as well as her kidneys. So simple cysts, basically round, oval, anechoic, no septations, and of course, they have nice posterior enhancement. And we can also have complex cysts. So for example, 62-year-old male, he's had right upper quadrant pain for several weeks, and now he's got a fever, elevated white count, and an elevated ALK phos. And we take a look, and there's this cyst, and you notice that there's stuff in it. And there's no posterior enhancement, really, not much. So this is actually an example of a hepatic abscess. And if anyone were to ask you the causes, everybody thinks, oh, it's an amoebic abscess. It's from amoeba. But these can also be caused by Klebsiella, E. coli, Pseudomonas, Streptococcus, and even tuberculosis. So when you're thinking about how to treat this, of course, you're going to get IR to drain it, but you're going to cover with both medications for amoebic infections and also broad spectrum antibiotics, particularly gram negatives. And you can also have these complex, like polycystic areas, and these are most often associated with the echinococcus, and they are hydatidid cysts. So that would be someone who's traveled, comes back and has some right upper quadrant pain and perhaps some jaundice. So the complex cystic lesions, they have septations, internal echoes, and maybe they have enhanced through transmission, maybe they don't. So some common things that cause these lesions are, of course, cysts, and uncommon are going to be more of the bad things like the abscesses. And very rare, they can be caused by an aneurysm, an AV fistula. You might have a hemorrhagic adenoma. And of course, the way to check on this stuff is, oh, where'd my color flow go? I guess it's not going to show up. Okay. So back to our trauma patient. And we continue to scan through the liver. And we said, oh, there's our nice cyst. And then wait, what? Wait. There's more stuff. We just can't even get to the kidney because there's more stuff in this liver. And yes, on CT, because she's stable, she gets the CT, we can see our nice cystic lesion. And then we can see this other kind of not really nice lesion there. So solid liver lesions. The most common by far are hemangiomas, and they're the most common benign liver lesion. They're typically hyperechoic on ultrasound and usually less than 3 centimeters. And then they're typically hypodense on CT. But the larger hemangiomas will often look quite different. They may look more like a Swiss cheese. And again, you're going to think about CT, MRI. So there's an example of nice little hemangioma. And it's always great when people have prior imaging that you can pull up. So as you're scanning through and you find these things, you can say, oh, it's the same as it was 6 months ago on the CT or on the ultrasound. So always check for that. And then this is actually from a patient who was in our CDU with chest pain. And I came the next morning and it seemed to be more like right upper quadrant pain. So of course I grabbed the ultrasound and I scanned through, and the gallbladder looked fine, but there's this kind of Swiss cheese thing looking there. And so that's the sagittal view, and take a look with the transverse view. And again, the gallbladder looks fine, but this is definitely not really normal. So I uploaded the images and I went over and talked to our radiologist, and he said, yep, it's either a bad oma, like a carcinoma, or it's a good oma, a hemangioma. And I said, well, what do I do? And he said, get a CT with contrast with delayed imaging. And happily for her, it was a hemangioma and not a carcinoma. So some other lesions that you'll see, solid lesions, adenomas, also fairly common, usually hyperechoic, not too big. Solid lesions, most common hemangiomas can have adenomas. You can have focal nodular hyperplasia, and metastatic disease will sometimes also appear as a solid lesion. So again, we're going to go to our CT or our MRI. I'll take a look at this liver. I'm like, that doesn't look quite normal. There's like these little tiny lesions kind of everywhere throughout. And yeah, they don't look normal. And they look kind of like targets. Here's another example. Bunch of these little lesions that look kind of like targets. So target lesions most commonly are bad things like metastatic disease, or they may be hepatocellular carcinoma, although that more typically is going to be one big tumor. But of course, you can have other things too. You can have lymphoma, focal nodular hyperplasia. This could be fungal abscesses or adenomas. Those adenomas are usually solid appearing, but not always. And for malignant tumors, the most common for these target lesions are going to be METs. And the primary hepatocellular carcinoma is the next most common, and those will have a pretty highly variable appearance. So this is an example of METs all throughout the liver. These are Mets from colon cancer, and these are more typically hypoechoic, and they have lots of vascular flow. And this is actually from lung cancer, and this is kind of almost more of a diffuse infiltrate with a kind of lesion with mixed echogenicity in it. And this is the kind of the more common appearance of hepatocellular carcinoma, one big solid tumor that tends to keep growing. And it can be, it's usually a mixture, kind of mixed echogenicity or more on the solid side. And again, hypervascular. These malignant lesions tend to be really hypervascular. So the take-home point for liver lesions is that most require some additional imaging. And always check to see if your patient has had prior imaging, because a lot of times you can just, put this to bed by saying, oh, I measured it, it's the same as it was on this CT 2 years ago, or this ultrasound 2 years ago, so I'm not worried about it. Or it's gotten bigger and I am worried about it. So liver summary: normal, homogeneous, less than 16 centimeters. Intrahepatic duct should be less than 2 millimeters, and air is never a good thing. So if it's diffusely inhomogeneous, think about cirrhosis, perhaps metastatic disease, or any kind of fatty infiltrate, but you also have to be thinking about malignancies. Cysts are pretty common. If they're round or oval and they has nice through transmission, they're probably just simple cysts. But then you can also have the bad stuff like infectious. You can have AB fistulas, all of those interesting things. Solid lesions are most commonly hemangiomas, and they might be adenomas, or of course other tumors. And target lesions are almost always bad. They're most often something malignant. But wait, let's go back to our patient. This was our lady with right upper quadrant pain, and we're thinking, okay, so our ultrasound was not that exciting. But in this view, this one of the common bile duct, there's something there that bothers me. It's this kind of hypoechoic and doesn't really look like the duodenum. And so let's go over and investigate that a little more. Oh, wait a minute. That is a pancreas, and the head looks rather large. And usually the pancreas is hyperechoic compared to the liver. And here, well, it's hypoechoic and it looks big, and you can actually see the pancreatic duct, which normally you don't really visualize. And you can see that there's some fluid adjacent to the pancreatic tail. And of course, some additional labs come back, like that lipase of 489. And then you begin to ask about her alcohol history. And you've made your diagnosis of acute pancreatitis. All right, so moving on. For those of you young enough or old enough to remember Monty Python, and now for something completely different: the spleen. So the spleen, of course, is on the left side in the left upper quadrant, and it's much smaller than the liver. But it's just as interesting. Interesting things about it: it's got a lot of recesses for like the colon and the kidney. It has a ligament, the gastrosplenic, which kind of holds it to the stomach. And you'll notice that it has this highly vascular hilum. And so we're going to take a look at what this looks like on ultrasound. So it's a little bit hyperechoic compared to its kidney. It's very homogeneous. It's not so broken up by structures. And it's harder to visualize because it's smaller. And you can see our lovely hilum. And if you put color flow on it, you can see that it's highly vascular. So it's homogeneous. It's usually a little more echogenic than the liver and the kidney, and plus or minus with the pancreas. And it's kind of shaped like a crescent. And then, well, how big should it be? And how do I even measure it? So, oops. All right. So we can all tell this spleen is too big. But what's too big? And what dimensions do I measure? So we're going to measure the spleen. We're going to measure the depth of it, basically from the tip of the superior part of the crescent to the tip of the inferior part. And then we're going to measure the width at its widest place. So here's a nice example of a normal spleen. It says length, but one of them is probably the width, the one that's 3 centimeters. So your spleen, the normal values are less than 13 centimeters in length and less than 6 centimeters in width. So here's a nice example of some splenomegaly, and you can see some ascites. So this is commonly caused, you can have it with liver failure, cirrhosis in particular, where you have portal hypertension, your spleen tends to get enlarged. So here's another example of splenomegaly, and you can see that this kidney is actually squished with this. And you can see that this spleen goes on and on. Now we're going down into the left lower quadrant and on and on. And in fact, so umbilically, in the umbilical area, you can still see the spleen. You can see it just above the bladder, and you can actually see it in the right lower quadrant. This was a gentleman who complained that he was having pain and he felt like he was growing a banana inside his abdomen, and he actually looked like he had a banana inside his abdomen. This was the biggest spleen I have ever seen. And this was an example of lymphoma. And in fact, this guy actually had mantle cell lymphoma, which is a more rare kind. And on follow-up, I thought for sure they'd take his spleen out, but they didn't. So he's been getting chemotherapy. And this was over a year ago, and he's still getting therapy for it, and they've never removed this ginormous spleen. I'm not sure if it's shrunk or not, because there's not been any other imaging. But that would be massive splenomegaly. So typically the causes of splenomegaly: congestive heart failure, portal hypertension. You can see it with leukemia and lymphoma, all varieties of lymphoma. Sometimes with hepatitis, you'll get splenomegaly as well. And then of course, in young folks, think mononucleosis, which is why we don't let them play sports. If you have somebody who tests positive for mononucleosis just for fun, you might measure their spleen. Some other infections can cause it. And then of course, hemolytic anemia. And then we all know in our sickle cell patients, they get enlarged spleens, and then they basically burn out the spleen and they kind of shrivel up from the sickle cell. So uncommon that you'd have splenomegaly, but those folks with glycogen storage diseases, occasionally you'll still see it with malaria, and if you have some fibrotic tissue. So the other thing to consider is that isoechoic hematomas can mimic splenomegaly. So I want to go back to that first case of splenomegaly that we saw. So you might be thinking that maybe there's like a little touch of fluid right there as you look through, and you're like, yeah, I think there's actually a little bit of perisplenic fluid. And you can tell that it's not quite homogeneous. So in fact, that's an example of an isoechoic hematoma. So the spleen isn't big, there's actually a hematoma around it.
Do you require sponsors to document?
I can hear somebody talking. Can you guys mute?
No, you do not. You do not. Have you read the Senate's Permanent Subcommittee on Investigations reports on your office? There was one in 2016. There was one in 2018. There was one in 2020. There was one in 2022. Spanning administrations. What they found is.
Okay, I've just muted everybody. So sometimes the spleen can have tissue around it that looks like a spleen. Come on, advance. So what are those? They're like little globs of spleen. And in fact, they're extrasplenic tissue. So they can be splenules, which are also called accessory spleens, splenunculus or spenunculi, or supernumerary spleen. And those are typically, it's splenic tissue, it's outside the spleen. They're usually 1 to 3 centimeters in diameter, kind of round. They may be congenital or they might be traumatic. And they're more common with someone who has splenomegaly. There's also something called splenosis. And this is almost always post-traumatic. and it's an implantation of the splenic tissue on the peritoneum. So someone is post-splenectomy, but a little bit of the tissue is left behind, and it grows on the peritoneum. So you get these areas that are spleen growing on the peritoneum. And these can be really tough to diagnose because they mimic METs. So if you find these on someone who's post-splenectomy, you have to really investigate to make sure that they don't have some type of cancer with METs to the spleen. And just like the liver, yes, we can have these nice, simple cysts that are round, anechoic, have a nice posterior enhancement. We can get them in single cysts, and we can get them in multiple cysts. Again, this is the same patient that we saw earlier with polycystic kidney disease, and their spleen has also been affected by this. So splenic cysts, typically post-traumatic, so it's an area of the spleen that's actually died, or they might be post-infectious or post-infarct. Again, you can see them with polycystic disease. These are congenital cysts are much more rare in the spleen than they are in the liver. They can also be parasitic, or there are mimics like vascular lesions. Oh, there's my nice Doppler flow. So that appears as a cyst, but actually if you put color flow on, you can see that it's a vascular lesion, probably an aneurysm there. So the spleen can also have solid lesions, just like the liver. And so you can see that this particular lesion is pretty hyperechoic, and it's also highly vascular. So there's multiple causes of splenic lesions that are solid: hemangiomas, hamartomas. They could be metastatic disease. They could be infarcts, abscesses, sarcoidosis, granulomas, hematomas. So multiple causes of solid splenic lesions. So this is an example. At the very end of the clip, you're going to see, maybe. Oh, for heaven's sakes. Oh, it seems like it's still loading. Okay. You can see you got a glimpse of it there. And then at the end, there is a solid, very echogenic solid lesion. And of course, we found this and was a trauma patient. They were fine. And we said, you need to follow up on this. And of course, they never did. So I can't tell you the outcome of that one. And then this is a patient that we were doing a fast on. And you can see the spleen and you can see the kidney. And as you're going through, you're like, wow, it's like Starry Night in the spleen. Cool. So those are examples of granulomas. And it turns out that this gentleman had actually lived in New Mexico and had histoplasmosis. So you can actually see that there's a couple of these granulomas in the liver as well. And sarcoidosis can appear like granulomas, or it can also look like metastatic disease. So sarcoidosis, really variable appearance. And again, if they don't have a known diagnosis, this would be something that you would be really concerned about, metastatic disease, and need further investigation. This is an example of METs from ovarian cancer, and you can see it's like got a cyst in the middle of it, large tumor infiltrating the spleen. So this is a person who came in as a trauma, and we ultrasounded the spleen as part of our FAST exam. And it's like, okay, what in the world is this? So the upper part is hypoechoic. The lower half or so looks pretty normal, and it's nice and vascular, except the upper portion isn't vascular. And we discovered that she previously had a splenic trauma. And in fact, the one of the splenic arteries had been coiled. So in fact, this portion of her spleen was no longer functional and was dead, and this part was functional. So that explains what we were seeing on ultrasound. So this is an infarct, and that's still functional spleen. Okay, now we're going to test you here. So here's our spleen. Here's our kidney. And then there's something going on up here. And you'll notice that there's like more vessels in this. Remember, I had talked about hepatomegaly, and sometimes you can have the liver cross right over on top of the spleen. So this is not some weird bifurcation of the spleen. This is actually the liver crossing over. And you can see that there's a lot of vessels in the liver, And in the spleen, there's far fewer vessels, and it's also hyperechoic compared to the liver. So that's one you don't want to miss. So this is a gentleman who was at the baseball game, came in getting a fast exam, and we noticed this area. It's like, oh, is that free fluid? Wait, there's some air in there, and there's some stuff floating in there. And yes, this is the stomach, and that's probably a lot of beer. So don't mistake the stomach. If your probe is angled too far anteriorly, you will wind up in the stomach. So you need to angle more posteriorly until you see the kidney. So don't mistake that for free fluid. And then, that splenic hilum, I kind of keep coming back to that. This was a 40-something-year-old female who came in looking like an aortic rupture. She was tachycardic, diaphoretic, not quite hypotensive yet, and was having severe abdominal pain. So of course we did the aorta, and I only have the single view here for you, but you can see it's normal. And I'll just tell you that the rest of it was normal. But to the left, to her left of the aorta was this mass, big mass. And we also noticed that there's some free fluid around the spleen. So of course, surgery came right down, and we figured there's got to be something vascular going on. And they took her to the OR, took out her spleen. And so never forget that, first of all, that a mass can be clotted blood. And secondly, that aneurysms are not limited to the aorta. So you can have other arteries that have aneurysms, including the splenic aneurysm. So that was a really interesting case. So the spleen, it's homogeneous. It should be less than 13 centimeters in length, or less or equal to 13 centimeters in length, and then less than or equal to 6 centimeters in width. So splenomegaly, common causes, CHF, portal hypertension, you've all seen this, but also bad things like leukemia and lymphoma. Other infections like hepatitis, mononucleosis, and then hemolytic anemia. And then we have some uncommon causes. So we have splenules, which are like little round extra spleens. And then we have splenosis, which is the implantation of splenic tissue in the peritoneum. And then, of course, the cystic lesions, typically post-traumatic, post-infectious, but they're rarely congenital, and they might be parasitic, and they might be an actual vascular lesion. Lots of causes for solid lesions, all sorts of them. And don't misinterpret hepatomegaly or the stomach in the left upper quadrant window. So when you see that kind of weird top to the spleen, you realize it's actually the liver reaching over and engulfing the spleen. So you want to say, wow, that's really big hepatomegaly, not there's something wrong with the spleen. And then, of course, you will never mistake the stomach in the left upper quadrant window for free fluid, because you have to tilt the probe backward or angle it posterior so that you can actually see the kidney. So the take-home point from this is basically you should always scan through the liver and the spleen when you're looking, when you're doing your fast exam, when you're doing your gallbladder. Take a look at the liver, take a look at the spleen, because if you find something, and you realize that there's a lesion there, most of these require additional follow-up, and it just might be that you will save somebody by discovering something early. So liver and spleen, we went through the objectives. We talked about normal sonographic appearance of both of those. And then we went through types of lesions for each of the organs and some differential diagnoses.